A very good morning to all of you and welcome to the first lecture in 2024. So we have invited Dr. Bodhika Samarasekera, who is the President, Sri Lanka College of Pulmonologists and consultant respiratory physician attached to District General Hospital, Negombo. He also is our own Vice President of GMOE. Dr. Bodhika Samarasekera was graduated from University of Sri Jayawardhanapura in 2001 and and obtained his MD in medicine from the University of Colombo. Dr. Samarasekera completed his local training at the National Hospital of Respiratory Diseases, Velisara, in 2011 to 2013, and his foreign training at Heart of England, NHS Trust, Birmingham, UK, in 2014 to 2015. Following the completion of his MD, he appointed as the consultant respiratory physician of the teaching hospital Jaffna, followed by DGH Hambantota, Gampaha, and Negombo. Dr. Samarasekera held the position of Joint Secretary of the Sri Lanka College of Pulmonologists for 3 years, that is 2018, 2020 and 2022, and the position of Treasurer of the College in 2019. He is currently a member of the Specialty Board in Respiratory Medicine for the PGIM. He is also a trainer and examiner for Diploma in Tuberculosis and Chest Diseases conducted by the PGIM Colombo. While being a visiting lecturer of Faculty of Medicine, University of Moratuwa, he also contributes as a member of the editorial board of the National Latent TB Guideline and Extrapulmonary TB Guidelines. So let me warmly welcome Dr. Bodhika Samarasekera to the GMO Academic Hour program. And another good news from the GMO Academic Subcommittee, we have been accredited as the CPD provider joining with the Ministry of Health, and we will be issuing CPD certificates from this year onwards. And we will update your branch secretaries on obtaining these certificates, and please be coordinate with your secretaries on that. And if you have any questions related to management of airway diseases, please send them over through the chat box, and we will attend to those questions at the end of the lecture. So let's listen to Bodhika Samarasekera. Over to you, sir.
Dear colleagues, wish you a very happy New Year 2024. And first and foremost, I would like to thank GMOA Academic Committee for giving me this opportunity. And also, I'm really happy that you all are continuing this CME work continuously. Especially, I appreciate the hard work of President Dr. Darshan Sirisena and Secretary Dr. Harithalutge for continuing medical education and encouraging. This is very important in patient care, not only the patient care, but also to career development of doctors, especially era that there are good opportunities in every part of the world for Sri Lankan doctors. So coming back to my topic, management of airway disease, what is new? I thought of doing the airway disease is one of the important topic, and I mainly talk on COPD and bronchial asthma. However, I thought of getting these are two separate lectures actually, but I thought of getting these two in this presentation because there is some confusion among our colleagues, and some patients who are having COPD, treated as asthma, and so we need to know that asthma and COPD is two different diseases, and management also different. So my outline will be diagnosis of asthma and COPD, and management of asthma and management of COPD, and I will briefly touch on pulmonary rehabilitation as well. Asthma when you're talking about asthma, is a syndrome of variable airflow obstruction, and it is characterized pathologically by bronchial inflammation and remodeling changes, and physiologically by bronchial hyperresponsiveness. So, if you can appreciate this picture, like this is the normal airway, but asthmatic airway, there is a inflamed wall and thickening wall of airway. And if during an asthmatic attack, there is in addition to the inflamed and thickened walls, there is a tightened smooth muscles and air trapping in alveoli as well. So it is important to reverse this. Asthma is always reversible disease, and correct intervention is needed to reverse this airway inflammation and remodeling. So there are different phenotypes of asthma. Allergic asthma associated with diseases, allergic diseases like eosinophilic airway inflammation, and these are responding very well to ICS treatment. And non-allergic asthma, the airway inflammation may be eosinophilic or neutrophilic, does not respond very well to ICS treatment. And asthma with fixed airway obstruction, airway remodeling, and late onset asthma, first time in adult life, non-allergic, and require higher dose of corticosteroid, and asthma with obesity. So there are different phenotypes of asthma as well. Coming back to COPD definition, COPD is a chronic obstructive pulmonary disease, is a common preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and or alveolar abnormalities, usually caused by a significant exposure to noxious particles and gases. So we should know that unlike asthma, the COPD, the symptoms are persisting, and it is not fully reversible. The airway obstruction is not fully reversible, and common significant exposures, noxious particles and gases are commonly that is associated with smoking, and also indoor and outdoor pollution, and especially biomass fuel. Talking about the pathology of COPD, it can be chronic bronchitis, inflammation of the and excess mucus, and also emphysema that alveolar membranes can break down. So, when diagnosing asthma, there are a few steps to be taken, and history is very, very important in asthma. And physical examination and measurement of lung function. History of signs, symptoms, and also the exposure and aggravating factors are very, very important. So what are the symptoms and signs of asthma? You all know that wheezing is one of the common presentation, and shortness of breath, chest tightness, and cough. These symptoms may vary over time in their occurrence, frequency, and intensity. Symptoms may be triggered or worsened by factors such as viral infections, allergens, tobacco smoke, exercise, and stress. So these are triggering factors. We all know that dust can aggravate asthma. In addition, animal dander is a common trigger, and pollen from plants, and mold and fungus on dam wall, and cigarette smoke, strong smells, and cold air, and sometimes exercise-induced asthma in certain individuals. So we should not forget that wheezing also found in other conditions like respiratory infections for a short period, and COPD, allergic bronchopulmonary aspergillosis, upper airway dysfunction, endobronchial obstruction, and inhaled foreign bodies. All these conditions can present with wheezing. So how do you diagnose and initially assess COPD? The symptoms of COPD is important. There's a chronic and progressive dyspnea, cough, sputum production, wheezing and chest tightness, and others including fatigue, weight loss, anorexia, syncope, ankle swelling, depression, and anxiety as other associated features. So these are the important salient features that symptoms are persisting. So assessment of symptoms are important. Firstly, you have to assess the breathlessness, progressive, and it is persistent and characteristically worse with exercise. And chronic cough may be intermittent and may be unproductive. And chronic sputum production. COPD patients commonly cough up sputum. So COPD should be considered in any patients with a chronic cough, breathlessness, and sputum production. So age and history also important, usually present more than 40 years of age. Asthma usually present at young age, childhood.
but COPD usually more than 40 years of age, and history of exposure to risk factors. So smoke from home, cooking and heating fuels, occupational and dust and chemicals, exposure history is very, very important. So smoking is one of the common cause of COPD. There are about 5 million deaths each year due to smoking. In addition, indoor air pollution due to biomass exposure we often forgetting, and so it is important. So if you appreciate this, like, very close environment, they using biomass fuel, firewood in a close environment. Sometimes they add some polythenes also in certain studies in Sri Lanka also, that many people are using polythene in this for cooking. Bags and all they put into in addition to the firewood. So there are 3 billion people exposed to biomass fuel worldwide, and 50% of global, that is the 50% of global population. So there are 1.1 billion smokers worldwide, but more than that, 3 billion people exposed to biomass fuel worldwide. So in addition, in our household settings, incentive sticks and also mosquito coils are very harmful using in a closed environment. So this in cooking, they use animal dung, dried pigs and crops, residues, wood, charcoal and kerosene and polythene. So COPD symptoms, so if you have shortness of breath, chronic cough and sputum with risk factors like host factor, tobacco, occupation and indoor-outdoor pollution, then you have to diagnose, you have to try and establish diagnosis. So spirometry is one of the important tests that to help to establish and diagnose of COPD, and we could differentiate that from asthma. What are the objective measurements of airflow obstruction? We have peak flow rate, peak flow meter can be used, and spirometry is used for the other to differentiate COPD. So in asthma, peak flow meter need to be assessed, like peak flow rates need to be assessed in all your patients. So this is important because this is like a measurement of lung function, and it's like the thermometer for asthma. So peak flow meter in asthma practice, you can use it in clinics and home monitoring and occupational asthma clinics, and it is helpful in diagnosing asthma, and it is 20% or more improvement after inhalation of bronchodilator suggests a diagnosis of asthma, and measuring of effectiveness of medications. So before PF are measured before and after treatment may show how effective the medicines are and can help to adjust the dose. And determine the severity of exacerbation, also important, and severity of exacerbation can be mild, moderate, severe. So peak flow helps to assess those things. And how to test in your clinic bronchodilator reversible test, measure a peak flow meter, measure peak flow reading and give a bronchodilator like salbutamol and wait for 10 to 15 minutes and measure peak flow reading again. If there is a 20% increase in the reading from previous, indication of a significant degree of reversible airway obstruction. You know that asthma is a fully reversible airway obstruction. So then you can establish diagnosis of asthma. So above 40 years, symptoms, cough and dyspnea and exposure to risk factors, then better to go ahead with the lung function test. Simple lung function is spirometry, widely available in Sri Lanka in many respiratory clinics. So all you need to know is like your FEV1, that's forced expiratory volume in first second, and also FVC, forced vital capacity, that total of air expired during the 6 seconds, and FEV1 to FVC ratio, it is usually more than 70%. If you have obstructive airway disease, that is less than 70%. Then this is the example of simple spirometry. Your FEV1 is 4 liters here, FVC 5 liters, the ratio is 0.8, so this is normal. But here, so test done for 6 seconds, and also FEV1 is 1.8 and FVC 3.2, so the ratio is 0.56. So there is FEV1 to FVC ratio reduction as well as FEV1 reduction. So that is obstructive airway disease. So we have to differentiate obstruction and restriction. FEV1 reduced in obstruction, the FEV1 reduced, FVC normal, and the ratio is reduced. In restriction, your FEV1 reduced, FVC also reduced, therefore FEV1 to VC ratio is normal. So how do you test the bronchodilatory reversibility in spirometry? There's the spirometry, you get a flow volume loop. So this is the normal, this green color. But in an obstructive airway disease, you get a concave curve. So when there is a reversibility, so this concavity is reduced, so FEV1 improvement more than 15%, that is suggestive of asthma after bronchodilator. So how do you, now the assessment of COPD, so that's the goal grades of severity of after obstruction. Still spirometry is helpful in diagnosis COPD after bronchodilator. If FEV1 to FVC ratio is less than 0.7, then it is, and there is no reversibility, then it is suggestive of COPD. So you have goal classification. This is important in management. So to assess the mild, moderate, and severe of COPD. The grading is important in treating. And in addition, COPD, we use that modified MRC dyspnea scales and 0 to 4 grades, and also CAT assessment, COPD assessment test. And this will be used to classify as a ABE classification. So earlier, a few years back, like the classification was ABCD. Now they have removed CD, and ABE classification is the current classification. So you assess the severity by the spirometry. There is gold 1 to 4 grading depending on the FEV1. Then you assess the exacerbation history and the symptoms. So assessing the symptoms by using MMRC, I showed you earlier, and the CAT questionnaire. So you can assess these. For example, this A, grade A, they don't have much symptoms. They have 0 or 1 moderate exacerbation. But B, still you don't have much exacerbations, but you have symptoms. So symptom scores are high, MMRC more than 2 and CAT 10. And when you come to E, there are, irrespective of symptoms, that there are moderate exacerbations and more than 1 leading to hospitalization. So more exacerbation means so you are at the level of E. So ABE classification is used, and the management also depending on these classifications. So in addition, we do a chest X-ray because COPD, the symptoms, the patient present with a cough or shortness of breath for a long period, you have to exclude other things as well. It will be helpful to establish diagnose asthmas. The X-ray may be normal, but COPD, there are hyperinflammation and some bullae can be visualized. And in addition, this is an opportunity to assess the patient underlying lung cancer or a chronic infection like pulmonary TB and interstitial lung disease can be assessed because they also can come present with shortness of breath, cough, and sometimes wheezing. So use of CT in a stable COPD, it is important to get a differential diagnosis, as I mentioned. Frequent exacerbation with excessive cough with sputum production and raising concerns for the bronchiectasis and atypical infections. And for intervention, so COPD patients, now the COPD management is developed in the world. So lung volume reduction surgery is being done, and also endobronchial valve therapy may be therapeutic option for patients if they demonstrate post-bronchodilator FEV1 between 15% to 45%. So there are options, so surgical and bronchoscopic options, interventional pulmonology evolved. So CT is important in that context. So lung cancer screening, annual low-dose CT scan is recommended for a lung cancer screening in a patient with COPD due to smoking, according to the recommendation for the general population. So how do you monitor these patients? We have a lot of tools, clinically assessment tools like COPD assessment test, action plan, and physiologically, like you have a spirometry, peak flow, and impulse oscillometry. And biologically, you have to assess. You can assess eosinophils and sputum inflammatory cells, and also a FeNO, that is called the fraction exhale nitric oxide, available in few centers in Sri Lanka. So after diagnosing, management of asthma is important. What are the goals of asthma management? So asthma and COPD, the management, there is a big difference. And so goal of asthma treatment is few asthma symptoms, no sleep disturbances, and no exercise limitation. That's called symptom control. And maintain normal lung functions. prevent flare-ups, exacerbations, and prevent asthma deaths, and minimizing medication side effects also important because including that these patients are on oral corticosteroids sometimes, and so well-controlled asthma can minimize the side effects of the medicines. The patient's goal may be different, and symptom control and risks may be discordant, and patient with few symptoms can still have a severe exacerbations. So in asthma management, it is important to assess the patient, confirm the diagnosis, and assess the comorbidities. Inhaler techniques are very, very important, the adherence of the inhalers and the techniques, and adjust the treatment accordingly. Asthma medications, non-pharmacological strategies, education and skill training, and also then you have to review the patient and assess the symptoms again, exacerbations, side effects, lung functions and comorbidities, and patient satisfaction, which is very, very important. So then the GINA guidelines, so this is 2023, so they have recently changed the steps 1 and 2. Previously, step 1 was as when required, short-acting bronchodilator. So now they have changed because steroids are important at the first step itself. So as needed, only low-dose ICS plus formoterol is recommended as a preferred controller and reliever. In a reliever also that instead of salbutamol, you are advised now to, as a first option, start with the as when required ICS formoterol combination. So that's the major difference between as previous guidelines. So step 1 and 2 as needed only low dose ICS formoterol, and so reliever as needed low dose ICS formoterol. But when you are using, if you are using a short acting bronchodilator like salbutamol, it is even as a reliever. They recommended better to use ICS with salbutamol inhaler, ICS alone. So that is the major change. Alternatively, take ICS whenever SABA is taking, as I mentioned, and step 2, low dose maintenance ICS can be done. So step 3, again, they recommended low dose maintenance ICS plus formoterol, and step 3, low dose, alternatively, low dose maintenance with ICS LABA, like that's a fluticasone salmeterol combination you can still use. And so explaining further the step 1, this is as need only ICS formoterol. So step 1 and 2, so you use as needed only low dose ICS and formoterol. For as a reliever also, you can use low dose ICS formoterol. So that is the major change here. And alternatively, earlier, for as a reliever, as needed ICS SABA. So if you use salbutamol, you have to use ICS along with salbutamol inhaler in these steps. So what is the background to changes in 2019? The risk of mild asthma. The patients with apparently mild asthma are at risk of serious adverse events. So they have they have found that 30% of adults with acute asthma, 16% of patients with near fatal asthma, and 15 to 20% of adults dying of asthma had symptoms less than 1 week previously. So that is important. So exacerbation triggers are variable, like viruses, pollens, pollution, and poor adherence. So inhaled SABA has been the first-line treatment for more than 50 years. This dates from an era when asthma was thought to be a disease of bronchoconstriction. Patient satisfaction, now we know that it's a major cause is airway inflammation. So it is justifiable to adding steroid as when as required as well. So patient satisfaction with an reliance on SABA treatment is reinforced by its rapid relief and of symptoms, its predominance in emergency department and hospital management of exacerbations and low costs. So patients commonly believe my reliever gives me a control over my asthma, which is not always true. So then often don't see the need for additional treatment. So regular and frequent use of SABA is associated with adverse effects like beta respiratory down-regulation, decreased bronchoprotection, rebound hyperresponsiveness, and increased allergic responses, and increased eosinophilic airway inflammation. So high use of SABA is associated with adverse clinical outcomes. Dispensing more than 3 canisters per year is associated with higher risk of emergency department presentation. Dispensing of 12 canisters of SABA per year associated with high risk of death. So when you're using steroids, always can I get the when you're using steroids, it is preferable is the inhaled steroids. So oral steroids can large dose required, it is slow onset action and great side effects. So inhaled steroids, whereas you use micrograms and small amount of dosage is required and fast onset action and has lesser side effects. Inhalation therapy is the most safe and effective treatment option for managing asthma. So we have to keep in that mind. So we have to educate all our patients on that. Patients are sometimes reluctant to get inhalation due to several myths I will discuss later. So inhalation therapy is the most safe and effective treatment option for managing asthma. Then step 5, there's a higher level care. So it is referred to a specialized center in advanced asthma. You have to refer, and you can add tiotropium, and you can add biologics, anti-IgE and anti-IL-F. I will talk on later. Can I? Please obstructing my slides. Can you remove this? Right, okay. So step 5 is a higher level care and add-on treatment. Preferred option is to referral to a specialized investigation and considered of add-on treatment. If symptoms are uncontrolled or exacerbation persists despite step 4 treatment, check your inhaler techniques and adherence. That is the most important step. So most of the times patients are not using their inhalers correctly and their compliance is poor. If not, then add-on tiotropium for patients more than 12 years of age with history of exacerbation. Then we have options of add-on anti-IgE omalizumab for patients with severe allergic asthma, and add-on anti-IL-5 mepolizumab or resulizumab for severe eosinophilic asthma. So, these drugs are commonly not available in Sri Lanka, but it's in guidelines. But we are trying to get these drugs down for specialized care of asthma patients. Other add-on treatment options at step 5 include sputum-guided treatment. This is available in specialized centers and reduce exacerbations or corticosteroid use. Add-on low-dose oral corticosteroid. This may benefit some patients but has significant systemic side effects, as you all know. And we need to assess these patients very closely and monitor for osteoporosis and other side effects. So in advanced centers, we do bronchoscopic guided therapies for uncontrolled asthma patients. That is called bronchial thermoplasty, thermal ablation using bronchoscope. So in addition, what are the general principles for stepping down? So once you start asthma treatment, inhalers, it is very important you have to have a good knowledge how to step down the controller treatment. That is very important. So our aim is to find the lowest dose that controls symptoms and exacerbations and minimize the risk of side effects. And when to consider step down is important. When symptoms have been well controlled and lung function stable for about 3 months is very important, and there's no respiratory infection and patient not traveling and not pregnant. So these are important factors when you're considering stepping down. So how to prepare for stepping down? Record the level of symptom control and consider the risk factors. Make sure the patient has written asthma action plan. Book a follow-up visit 1 to 3 months in time. So how do you step down? Through variable formulation. Stepping down ICS dose by 25% at 3 months intervals is feasible and safe for patients. So ICS dose can be reduced by 25 to 50% every 3 months, and then that is the best way of stepping down these patients. So what are the myths that patient carry? So you have to address when the patients are on inhalers. So they are carrying a lot of myths, and that is the problem with managing our patients. They think regular use of inhalers are habit forming and addictive. So we have to address that's not. And asthma can be fully cured, or asthma comes and goes, is not always there. And oral medications are better than inhalers, they think. You cannot lead a normal life of asthma. So you have to explain your patients that there are Olympic gold medalists. Even in Sri Lanka, there are Asian level gold medalists who are asthmatics. They have control very well with inhalers. So you cannot exercise and play. That is not true. You can nicely treat exercise-induced asthma, and before exertion we can give some inhalers and they can have near normal life. So other myths is a pregnant woman should not take inhalers. So that is not true. Pregnancy, all the inhalers you can use and take without any side effects to the baby. So one cannot die due to asthma, some people are thinking, but asthma is a life-threatening illness. Then coming back to COPD. So asthma and COPD management are different. So that's why I took these topics together. And as COPD managements, we have a lot of options still: inhalers, biologics, medications, healthy diet, exercise, and NIV therapies and oxygen. So there are many options in managing COPD patients. There are symptoms day to day. What are the goals for treatment of stable COPD? So you need to, the first goal is reduce symptoms, relieve symptoms, improve exercise tolerance, and improve health status. And then to reduce risk, which is prevent the disease progression, prevent and treat exacerbation, and reduce the mortality of these patients. So management of COPD, so we need to correct diagnosis with a good history and also spirometry, and then initial assessment and classify to FEV1, goal 1 to 4, and exacerbation history by goal ABE, and other smoking status and alpha-1 antitrypsin deficiencies, and also comorbidities. So then you can initial management with lifestyle modifications, smoking cessation, vaccination, initial pharmacotherapy, and so on. And then you have to review these patients. So I explained that the classification of COPD is very important. AB classification to assessing, managing these patients. So group A patients, they have very less exacerbation, 0 or 1 moderate exacerbation, and they are less symptomatic. So MMRC 0 to 1, CAT score is less than 10. So bronchodilator is enough for these patients. So salbutamol or a short-acting antimuscarinic drug agent. So it is important. But group B, they are symptomatic even though they are less having less exacerbation. So that is called LAMA, long-acting beta agonist, and LABA and LAMA, long-acting antimuscarinic agents. So so this LAMA-LABA combination is very important in managing these patients, symptom control wise or prognosis wise. So unfortunately, LAMA-LABA combination is not available in Sri Lanka, but we have to try and get it down. Earlier we had indacaterol and glycopyrronium combination, but it's also not available. So LAMA-LABA is the recommended combination for group B, and group E you can still have again LAMA-LABA, but patients having high eosinophils, you can add inhaled corticosteroid. That's called triple therapy. LAMA, LABA, and ICS. So triple therapy is indicated when patients are having more eosinophils, usually less than 300. So in management, so you have to review the symptoms, dyspnea and exacerbation, assess the inhaler techniques and adherence again, like asthma, and non-pharmacological approaches, and adjust, escalate, and switch inhaler device and molecules, and also de-escalate whenever necessary. So, how to treat an exacerbation? When exacerbation, sometimes patient may on LABA or LAMA. Then you can start LAMA-LABA combination. So you can add steroids to LABA when eosinophil is more than 300 or eosinophil is more than 100 even if they are having 2 moderate exacerbations and 1 hospitalization. So, so consider these LABA-LAMA combination adding ICS, and if eosinophils are less than 100 and no response, then roflumilast is a PDE4 inhibitor. When patients having FEV1 less than 50% and having chronic bronchitis, they are recommended in guidelines. I think Sri Lanka it's still not available and we are not using. But in former smokers, still azithromycin available. We can try azithromycin 500 mg daily for 3 days and 250 daily for 3 months, and azithromycin can be introduced to these patients. So eosinophil count also important. Key consideration before adding ICS is exacerbation history, eosinophil count, and potential need for antibiotics. So less than 100 eosinophil count, if it is less than 100, there is no need of ICS. Then variable cutoff is the 100 and 300. But if they are having 2 moderate exacerbations, antibiotic treated exacerbations, and current smoker, it is still not recommended. But former smokers, exacerbation treated with oral corticosteroids, more than 2 moderate or severe exacerbation, then still you can try adding inhaled corticosteroids is important. But eosinophils more than 300, ICS is indicated in these patients. What are the non-pharmacological management? So, more than asthma, like it is very important in COPD, the non-pharmacological management is a special program, and usually we refer these patients to the pulmonary rehabilitation program as well. So, the patients, less symptomatic patients, that patient group A, the smoking cessation is important and physical activity is recommended, and depending on local guidelines, the influenza vaccine, COVID and pneumococcal vaccine every 5 years, influenza every year and COVID every year, and these vaccines are important. And B and E symptoms like more symptomatic patients and more exacerbations, then smoking cessations and pulmonary rehabilitation and continuing physical activity and influenza vaccination, COVID vaccination and pneumococcal vaccination is important. So what are the non-pharmacological treatment options? That education and self-management, improving physical activities, pulmonary rehabilitation programs, exercise training, self-management education, end-of-life palliative care. We often forget in these patients, end-stage patients of COPD, palliative care is important to make them comfortable, and nutrition support is the respiratory muscle strengthening is important with the nutritional support and exercise, and vaccination, as I mentioned earlier, and the oxygen therapy. So oxygen therapy, it is important. The long-term administration of oxygen increases survival in patients with severe chronic resting arterial hypoxemia. Oxygen is a drug, so you need to prescribe. And in acute exacerbation, we often see that patients being given high oxygen levels. So COPD patient, the recommended oxygen is 88 to 92, the oxygen percentage. So, and the ventilators, so the college involved in starting home oxygen therapy, and we have started a few centers and expanding island-wide. We are providing oxygen concentrators in few centers free of charge with the government. That's the last year's project. This year we are starting with so NIV also beneficiaries in these patients. So we are trying to get the permission of the ministry to deliver NIV also free to these necessary patients. So in patients with severe chronic hypercapnia, that is PaCO2 more than 53, these patients with a history of hospitalization for acute respiratory failure, long-term non-invasive ventilation may be considered, and there are evidence it be. So, and how to prescription? Oxygen is a drug, so always you need to prescribe. Arterial hypoxemia is defined as a PaO2 less than 55 and PaO2 more than 55 and less than 60 with right heart failure and erythrocytosis. And you can prescribe supplemental oxygen via a cylinder or oxygen concentrator, and titrate to keep saturation more than 90 but not too high. So recheck these patients 60 to 90 days and assess if supplemental oxygen is still indicated or if prescribed supplemental oxygen is effective. So pulmonary rehabilitation program is this program include education, exercise conditioning, breathing techniques, respiratory therapy evaluation, nutritional support, and psychological support. That's a combination of respiratory, physical, and social work. And psychological support also very important in these patients for adherence of treatment. So that's a big different long lecture, so separate lecture. So I will brief on that. And finally, we are doing our sessions in Respire 2024 in February, that is 18th to 20th February at Cinnamon Grand, Colombo. There will be 11 foreign speakers on site. So this is a good opportunity to meet world authorities. We have invited World ILD Authority, Professor Athol Wells, and Pleural Effusion Authority, Professor Gary Lee, and interventional pulmonologist, well-known interventional pulmonologist, Professor Pan, and these people, and Deepak Talwa from India. Many of these speakers will be on site, and this opportunity to discuss your problems with this, and there's a wide variation of all the respiratory topics will be covered in this session. So it's a good opportunity to save your dates for the sessions. And thank you again for giving GMOA, and as Vice President, I'm really happy that you all are continuing this academic program, CME program. So wish you all the best for the new year, and thank you very much for giving this opportunity.
Thank you very much, sir, for that very informative lecture. And we have received one question from our audience. Dr. Prasad Herath says, we have recently noticed persistent cough following upper respiratory tract infection with whitish sputum or even dry cough triggered by AC probably. So can you please guide us on the management?
Well, that's an excellent question. And as you all know that these days that there are several viral infections going on, especially influenza, para-influenza, and also COVID variants are going on. So these infections can trigger underlying respiratory diseases such as asthma. Asthma can be triggered by well-known viral infections these days. So that then with these patients that asthma also need to be treated as well as the viral infection. So that's the persistent cough can be, it's persisting these days, so very difficult to treat. So their underlying lung disease should be managed properly. Thank you for the question.
Thank you for answering that question, sir. And let's wind up the session for today, and hope to meet you in 2 weeks' time. Thank you.